Right, sorting things out. There we go. Right, good afternoon. Thank you ever so much for inviting me along. Today we're going to talk about ME/CFS and long COVID, and a new collective term that's emerging, infection-associated chronic conditions. So these are conditions that, for the majority of people, can be traced back to an infectious onset. So you might experience the flu, or in the case of long COVID, it would be, of course, the COVID-19 virus. And these affect people in that they just can't recover. So they're waylaid by the infection itself, and then they just can't recover their previous level of health. And this can go on to develop into a chronic disease state. So a bit about the ME Association, if you're not already familiar. We're one of the leading charities in the UK for ME/CFS and long COVID. We've been working in the ME/CFS field since 1980. Our medical advisor is arguably the most well-known expert, Dr. Charles Shepherd. During the pandemic, it became pretty obvious to us that there was going to be a huge need to provide healthcare support for people who weren't able to recover from COVID-19. So we started putting out expert information as soon as possible to try and help them. So the ME Association itself, we provide very high level of professional support. We have our telephone helpline available 6 days a week, every day of the year. We provide expert knowledge. We have a panel of experts, including Dr. Charles Shepherd. Our reliable information, we have over 100 items of literature which can be downloaded for free from the website, relating to all aspects of ME/CFS and long COVID, diagnosis through to management, through to treatments, and everything else around that, so raising awareness and things of that sort. Our key focus has been to raise awareness. In the past, ME/CFS has attracted, a fair degree of stigma, particularly from within the medical community. But I personally like to think that we can draw a line with the past now. There's been some key developments that have perhaps changed the landscape for people with ME/CFS, or is at least beginning to change the landscape, which we'll talk about in a minute. One of our other key efforts is to work with the NHS and social care services to try and improve the healthcare provision that's available for people with ME and long COVID. And as a leading charity, we also invest directly in medical research, whether that's biomedical research or healthcare related research. Just a little bit more about our efforts to improve health and social care. So the National Institute for Health and Care Excellence, or NICE, produced clinical guidelines for just about every disease under the sun. In October 2021, we finally were able, after about 3.5 years of hard work, to publish a new revised guideline, which is really, really good. And I would recommend that whether you're a patient or a carer of somebody with ME, or even of somebody with long COVID, that you try and find the time to read through the clinical guideline, because it provides recommendations to the NHS and social care about how people with ME or long COVID should be treated, should be managed, and it allows you to see what should be available to you. Can't guarantee that everything in there will be available to you, but at least it lets you know what should be there. So within the charity, after the guideline was published, we quickly realised that the next priority would be trying to get all these recommendations implemented. So we put together a pilot scheme, and I've overseen a small team of former and current healthcare professionals who have ME/CFS or long COVID themselves, to try and engage with integrated care boards to try and raise the profile of ME and long COVID and the importance of providing healthcare services. They focused on one single integrated care board because this was a new thing for us to do. And they focused in on Buckinghamshire, Oxfordshire and West Berkshire integrated care board. And they had some really significant successes after just 6 months. So that integrated care board has carried out a complete review of their service provision, and they're now moving towards new integrated service developments, which we hope will be in place from next year. Across the country, across England, around 28%, so that's about 12 out of 42 integrated care boards, have been reviewing their service provision. We've been engaging with them. They're looking to produce these new integrated services. So essentially what you'll have is a service that will accept referrals from GPs for people who've got ME/CFS or who have ME/CFS symptoms following a COVID-19 infection, or who have long COVID. And the differential now is that if you have organ damage or you have other symptoms, so like the breathlessness and things like that, then you're more likely to be in the long COVID diagnosis box. If you meet the diagnostic criteria, which we'll come on to for ME/CFS, but your infectious trigger was COVID-19, you're now more likely to receive an ME/CFS diagnosis. The situation's still in flux, but what we're trying to do is to ensure that there are these specialist services available near to everybody so that we all have access to a specialist service near to where we live. In Suffolk and North East Essex, this is the SNE, they've developed a brand new integrated service, which has cost £5.5 million over 5 years, and they've just accepted a new bid. I have organised a clinical conference next week. We've got about 220 NHS clinicians already registered to attend. It's not open to the public, but the clinical commissioner from Suffolk and North East Essex will be announcing more detail around how the service has been structured, etc. Just to say that in Suffolk, I certainly regard it as a model for the rest of the country because it has adopted just about all the NICE guideline recommendations, and it looks really good. A little bit more, if I may, and then we'll get cracking. So we do invest in medical research. We have done since 1980 when we were formed as a charity. It was the main drive to become a charity, in fact, was to try and stimulate more research into ME/CFS. Back in those days, it was very hard to get researchers interested in this area, so we were trying to do it ourselves. So since then, we've invested as much as we possibly can in research, about £3 million to the beginning of January of this year. We've supported, or we helped to create, and we've since supported the operational costs of the UK ME/CFS Biobank, which is at the London School of Hygiene and Tropical Medicine. This is where they store biological samples, so blood samples mainly, and clinical data for people with ME/CFS, people with severe ME/CFS, people with multiple sclerosis, to enable samples to be compared across 2 different diseases, and also from healthy controls. And the idea being then that researchers from around the country can use the samples from the biobank. It costs them less to do it this way, and it means we can help to try and stimulate more research. We've also announced this year so far that we're supporting a fairly large clinical trial in Canada of a drug called low-dose naltrexone. And we're also going to announce, I hope in the first 2 weeks of August, thereabouts, what will be for the whole field the single biggest charity investment ever in biomedical research. So, watch this space, really very exciting. Just going to play a little video now for those of you that aren't familiar with how bad ME can get. This is Hannah. She was severely affected. Also, just to say that if you're interested in my own story, some people find it quite helpful. I've written about surviving ME. It's now 25 years after my diagnosis, but I wrote this 5 years ago. That's available on the MEA website. But Hannah's video is sound and music, so if you're sensitive to sound and music, please sort of mute now. The video of Hannah's video is up on our ME Association YouTube channel if anybody wants to watch it all the way through. One of the points raised is the low rate of full recovery in ME CFS. It's been estimated that only about 5% of people who develop this illness actually managed a full recovery. That is a sustained recovery, symptom-free, back to full functionality. But to be perfectly honest, there's not been enough research examining recovery and improvement. So to be perfectly honest, we really don't know what the true situation is. There we go. Right. So again, people who've got ME/CFS are probably more than familiar with what it all means, but it can be a bit confusing with all these names and terms and phrases and things. So the historic term for what we're talking about, it has been post-viral fatigue syndrome. So that's the entry that is actually still within the World Health Organization's international classification of diseases, which countries like the UK and almost all countries around the world actually use, and which the NHS in the UK have adopted, because the NHS, when it diagnoses somebody, you should have a code applied to your patient records, and that code should reflect the diagnosis that you receive. So within the NHS, they will usually not code to post-viral fatigue syndrome. They'll usually code to either ME or CFS. But PVSS is the original parent term, as they call it. And then below that, so within that category, would be myalgic encephalomyelitis and chronic fatigue syndrome. And there have been other descriptive terms for this disease over the years. Within the WHO, the World Health Organization disease classification, they're all listed there. And long COVID, I think everybody uses long COVID now, but there were, during the pandemic and after the pandemic, various attempts to try and come up with phrases. So that's what they are as well. Just to say, chronic fatigue syndrome generally hated by the patient community, myself included, because it has served to put the focus on a single symptom, i.e. chronic fatigue, which we'll just talk about now, well, in a minute. So, as I said, the vast majority of people can trace the onset of their disability, ill health, to an infection from which they just simply don't recover. In fact, it can often feel, it certainly felt to me, like I was still infected because the symptoms initially were pretty much the same. Then other symptoms can develop. Disability can get worse, incapacity can get worse, your ability to think clearly can get worse, your ability to walk. So it can really sort of affect everything. And yeah, research is suggesting that around 5 to 10% of people acutely affected by an infection are at risk of not recovering. And then going on to develop what was called post-viral fatigue syndrome, but we're now coming to think of as an infection-associated chronic disease state, as it were. So why might someone develop ME? Well, we talked about the predisposing factors a little, but it's generally felt that there's likely to be a genetic component, meaning that some people are more susceptible to developing ME/CFS, and it might also explain why we commonly see more than one family member affected. Good friends of mine, they have, well, they got one friend in Wales at the moment. His wife's had it, his daughter's had it, or still got it, and his adult son is still very severely ill with it. So it's not uncommon to see it in multiple family members. There's a big research study going on at the moment, the biggest ever genetics study into ME/CFS, called the Decode ME study, being completed by Professor Chris Ponting at the University of Edinburgh. And they're going to start releasing results later this year, I believe. And Chris is very excited. So I'm hoping that he's found something quite significant. So watch this space for that. So we did talk quite a lot about precipitating factors. So these are the infections that seem linked to triggering or developing ME/CFS, and they can be pretty much any infection, to be honest, viral or bacterial. They can even include Ebola, believe it or not. So 6 months after somebody's been treated for Ebola, certain people can still experience similar symptoms and be unable to recover fully. Historically, ME/CFS was linked to pesticides. I remember sheep pesticides in particular was one of the links, but they were never sort of validated really. So there's a lot of research still to be done. We're funding some research being done through the Biobank at Bristol. They're exploring something called HHV6, which is another form of infection, to see if that specifically is one of the major triggers. Perpetuating factors, so what do we know about what keeps this illness going? So there has been a lot of research into ME/CFS. The difficulty is, oh, something's gone wrong with my slide there. Anyway, the difficulty is a lot of the research has been on small numbers of people. So it needs to be replicated by much bigger and better studies, more robust studies, in order to confirm these early findings. And more importantly, for medicine to accept these early findings. But, we're very confident to say that ME/CFS is a disease. It has biomedical causes. It's not a figment of people's imagination. It's not all in your head, which is one of the stigmas that I was referring to earlier. So the research that has been done has found abnormalities or impairments in all these various different bodily systems that I won't go into detail. I've got a rather nice graphic here, which sort of explains where these things might be influencing bodily reactions or inactivity. Generally speaking, I think if you speak to most people with ME, they will talk in terms of it affecting their energy levels, their ability to sort of get up and go, even with the most minor, inconsequential daily tasks. But there is a lot going on that can be contributing to, generally how we feel and how we're able to function normally. So we've just had some new research come out this year, again, from Chris Ponting in Edinburgh and Gemma Sounds. So we've increased the prevalence. This is how many people might have ME/CFS in the UK. That's now increased officially to 404,000, so just over 400,000, which is a step up from historic estimates of 250,000. So it's still about 2 times as many people that get multiple sclerosis. And if you use another estimate, that is the number of people with long COVID who meet the criteria for ME/CFS and don't have any other symptoms and don't have any organ damage, then we could be looking at a patient population of 1.35 million. This is all based on estimates, of course, but this is the nature of epidemiology research. They make the best of estimates they can based on the best evidence that is available. So I think the 400,000 figure is the best estimate we've ever had for ME/CFS. The COVID-19 ME/CFS figure is of 950,000 is less reliable, So, I'm hoping we can get some more research done there to sort of confirm it or not. But even so, it's, a real health crisis. So it's a huge number of people who, generally are unable to work, and it's had a big impact on the economy. Um, yeah. So what healthcare is available in the UK today? Well, there's around 45 ME specialist services, and there are still, we think, around 90 long COVID clinics in England, at least. In Wales, they've been integrating long COVID clinics with ME/CFS, so they've been opening the doors for referrals to ME/CFS, and that's meant or will mean that in each of the 7 health board areas or regions in Wales, there will be an integrated service. So more people in Wales will have access to specialist care. At the moment, there are only 2 ME services in North Wales to cover the whole of Wales. So from my point of view, I see it as an improving situation, but there's still an awful lot of work to do. I've still got to convince, 2/3 of integrated care boards in the UK that having integrated services is a great idea and they should fund it. Instead, a lot of them are just closing down long COVID clinics, leaving patients with nowhere to go other than the GP, who doesn't have the specialist knowledge or really the time. So the other key thing to mention is, of course, that both long COVID and ME/CFS affect far more women than men. So it is more than chronic fatigue. I'm not going to labour over this point because I've spent too much time, I think, talking about earlier stuff. But I just want to stress some of the presentations that I give to healthcare professionals, that, they need to be considering more than just chronic fatigue all the time. Chronic fatigue as a symptom affects an awful lot of diseases. So chronic fatigue within multiple sclerosis, for example, is one of the most difficult symptoms for them to manage. It's one of the most impactful symptoms. So these slides are just really to highlight that chronic fatigue affects a lot of different things. It's not just ME/CFS. There are problems in that people get misdiagnosed, so they might be diagnosed with ME/CFS, but then hopefully when they see a specialist, the specialist realise they've got the wrong diagnosis, and they will refer them for the right diagnosis. The importance of that can't be stressed enough, because ME/CFS and long COVID at the present time have no effective treatments. So if you've been misdiagnosed, you could go for a very long time without realizing you've got the wrong diagnosis, and the right diagnosis might actually have led to effective treatments. So, for example, if sleep apnea is the main reason why you are feeling the way you are, and you get that correctly diagnosed, then treating sleep apnea might improve your symptoms. And it might mean that you can return to normal life a hell of a lot sooner than you would do if you were carrying around an ME/CFS diagnosis. So, sorry, the ones in red, by the way, that are the most commonly associated diseases with ME/CFS, the most likely to be misdiagnosed as ME/CFS. Yeah. So I talked about the NICE guideline. The following slides are really just focusing in on, what is now official advice. The official definition of ME/CFS is that it is a complex chronic medical condition affecting multiple body systems, and its pathophysiology is still being investigated. That is just to say that we don't really understand what's causing or perpetuating ME/CFS at this present time. And here, it's been estimated that 50% of people who develop long COVID meet diagnostic criteria for ME/CFS. But it's also generally regarded as a fluctuating condition. Now, that can upset some people when we use phrases like fluctuating. What we mean by that is that, it doesn't mean that you have the illness one day and you don't have it the next day. It means that the severity of your symptoms, and in fact the symptoms themselves, can fluctuate over a period of time. So, your the debilitating fatigue might be incredibly bad with you today, but it might be a little bit easier tomorrow, whereas tomorrow pain might be a much more severe symptom than it was today. That's what we mean by fluctuating. You can also fluctuate in terms of the illness severities themselves, which I'm going to show you in a minute, because ME and long COVID are both subject to relapse, unfortunately. So here we go then. So the NICE guideline defines ME/CFS as having 4 illness severities. So mild, moderate, severe, and very severe. So people with very severe ME/CFS are unable to leave their beds, dependent on care, need help with personal hygiene, eating, very, very sensitive to external stimuli, like light and noise. May even need to be tube fed. Malnourishment can be an issue. People with mild ME/CFS, and again, you know, when we use the word mild, it's arguably the wrong word, really, because, you know, you're still significantly impacted by the symptoms and by disability, but you may be able to, you know, return to work in some capacity or do more, generally. But the chances are you still need to take extra time off to cope. So again, I don't always like using the word mild, but these are the definitions from the NICE guidelines. So, and yeah, so you can fluctuate over time between these categories. There may be triggers. So somebody who's in a mild category this year or for the first few months of the year might attract a viral infection or something that knocks them back down to being severely ill, and they may be back down here for months on end until their finally symptoms stabilize and then start to improve again, and they can move back up into moderate and be able to do a little bit more. So the NICE guideline definitions then. So your ability to engage in occupational, educational, social, or personal activities is significantly reduced from pre-illness levels. That's quite important. And that symptoms are not explained by another condition. So the process of a diagnosis is generally that a GP will make the diagnosis, and then they will run blood tests and carry out a full assessment. Well, this is the ideal. And then they will ensure that before they diagnose you with ME/CFS, they've checked that your symptoms are not being triggered or caused by something else that can be treated. And then they should refer you to specialists, and the specialists should then confirm your diagnosis. So the idea is that, you know, there's this sort of double checking going on. And again, it's important to stress, because this has happened and continues to happen. People, when they get a diagnosis of ME/CFS, will experience new symptoms, and it is incredibly important that you get the new symptoms checked. There's a tendency in the past from doctors, unfortunately, to sort of tell people, well, you've got ME, so it's, you know, your new symptoms are just ME. So this is not always the case, okay? And things are getting missed. So, you know, I know it's difficult engaging with a GP, I know that, but we've got to try. And if you've got specialists, you know, make appointments with specialists to just confirm that your new symptoms are not something else. Don't assume it's all down to ME, is my message. So the 4 main symptoms that you need to qualify to meet the criteria for a diagnosis: the debilitating fatigue. So it has to be worsened by activity, but it can't be caused by you running a marathon. So it's got to be, you know, a kind of fatigue that is abnormal. Okay. Post-exertional malaise, all right, another terrible term to understand. Essentially, if you try and do too much, all your other symptoms flare up, you feel a hell of a lot worse, and it sets you back. Now that flare up, the onset of those worsened symptoms can be delayed. We don't understand why, but a lot of people experience a delay until it hits them. Some people think that post-exertional malaise is unique to ME and to those people with long COVID who meet the ME criteria, because post-exertional malaise is a feature within long COVID as well. I personally don't think so. I just think it's not very well explained. And if it was better explained, then I think other diseases would recognize it. Multiple sclerosis, for example, is something I think this may well be a factor in that isn't recognized at the moment. So the other key thing is this sleep disturbance, and then the final one of the key four is these cognitive difficulties, so the brain fog. Again, these four symptoms are also relevant to long COVID too. We've produced a guide for primary care, so for your GPs. It's available on the MEA website, or email me through Helen at the end, and I can provide you with the guide. All our literature on the website is downloadable for free. But it's just a useful reminder to GPs on how to diagnose, what they should be looking out for. It's also very useful for patients to know what they should be looking out for too when they see a GP. So when you, as I say, when you get a diagnosis, there should be a full medical history carried out, physical examination, and then blood tests to exclude other things. There's also several conditions that you're perhaps more likely to develop at some stage with your ME/CFS. So these can be an increased allergies, chemical sensitivities. Fibromyalgia often goes hand in hand with some people with ME/CFS. So fibromyalgia, the pain is sugar. So the pain is more relatable to bone and joints. Sorry, excuse me, we'll sort that out. Ugh. There we go. Sorry. So the fibromyalgia is more relatable to sort of, I would say, bone or joint pain, whereas the pain within ME/CFS is more muscle pain, muscle aches. But quite often they can be diagnosed together, or people might attract fibromyalgia diagnosis later on after they've been diagnosed with ME/CFS. Hypermobile joint syndromes are fairly common too. Interstitial cystitis, which I've had to practice saying a lot because I kept mispronouncing it. We've got a leaflet on all of these. We've got information on all of these. Irritable bowel syndrome type symptoms, migraine type headaches, very, very common, and postural orthostatic tachycardia syndrome, and orthostatic intolerance, but that is a recognized symptom. So we'll talk about that quickly in a minute. Doesn't mean you're going to get all of these, just means that these are common. And then there are some other things which are less common, which we've got there. So other common symptoms, this orthostatic intolerance and dysfunction. So this relates to your autonomic nervous system. Generally, a problem with your, the blood not flowing to your brain as quickly as it should when you go from a lying down to a sitting up position, or a sitting down to a standing position. You will feel dizzy, faint. Your heart might race. You may feel nauseous or nauseated, I think is the correct pronunciation. You may even faint in the worst case examples. So that's important to look out for. Postural orthostatic tachycardia syndrome, which is another form of it, can also be tested for by a GP or specialist service, and there are treatments that may help. It's also important to check either with your GP about vestibular disturb. I think that's the right phrase. I'm not a medical doctor, obviously, but problems with your ears. So it's important to check your inner ear balance has not a problem, because that can also cause similar symptoms. So dizziness upon standing, and general nauseated feelings. And then we have all these other symptoms as well. So 4 key symptoms to diagnose, and then all these other symptoms you may experience, which help to confirm a diagnosis. This slide is just really to highlight how bad it can get. Again, I think part of the stigma was that doctors and society didn't appreciate how bad it could get, how extremely limiting a person's life can be with ME/CFS when it's in particular very severe. So this slide is just to really highlight, the worst. And then I just wanted to highlight how many symptoms we share in common with the long COVID side of it. So poor temperature control is another key one. So you might feel unusually hot or unusually cold at times. It might affect just your extremities. You might be getting cold hands or feet, or hot feet. That's another common one. So these specialist services that you should be referred to, that should be available locally, but I'm desperately trying to work on that. So, which is part of why we're doing this clinical conference next week. They should involve specialists, obviously, a specialist service. So you hope to see people who are very familiar with ME/CFS, who understand it, who follow the NICE guideline recommendations. That is the ideal situation. That is the plan. That's our goal. One of our priorities is we want a physician or several at every specialist service. But at the end of the day, it all comes down to funding, unfortunately. So you're likely to see, or perhaps ideally likely to see, experts who've got backgrounds from all different medical disciplines. So this just really is to highlight that at the moment, ME/CFS and long COVID are not acknowledged by any medical discipline in terms of it's our problem. So that, even neurology, which historically ME/CFS has been recognized as a neurological condition, but neurology don't accept it as theirs. So what we need, what we're trying to work towards, is to find a medical home. My personal belief is it should be part of immunology, or perhaps even infectious diseases, but that's just my personal viewpoint. But it would help if we had a medical home, if we had a specialism that said, right, that's ours. It would help in terms of NHS resourcing, and in other ways. So this slide just really talks about, what you should expect at a specialist service according to the NICE guidelines. So occupational therapists, physiotherapists should be working with you on a care and support plan. What they shouldn't be doing is treating everybody the same. They should be tailoring their advice, their recommendations to you as an individual. They should be recognizing and understanding your own needs. So no two care and support plans should be the same. But these are the kind of things that they should be helping you out with. They should not be offering graded exercise therapy. So this is where, as a charity, we fell out with the previous NICE guideline and with clinicians who were following previous advice and recommending graded exercise therapy, and basically pushing people who are far too ill to do it through it and making them worse as a result. So we've come a long way since then. We're not against exercise. I'll make that point. If you can exercise, and it's the kind of exercise that you can manage, going for a short walk, sitting in the garden, enjoying the fresh air. I mean, to me, that was sufficient exercise when I was at my worst, or trying to improve from being at my worst. It has to be proportionate. It has to be relative, and it has to be tolerable. We just don't want people being pushed through programs that don't take account of their health and disability, and we certainly don't want GPs telling people to go to the gym. So the other advice you'll receive, it should be all-encompassing, basically, and it should include a review of your mental health and well-being, because I know there's this stigma again, but having ME/CFS does impact your mental health. Okay, I don't think there's any argument there. And, within every specialist service, there should be the ability for them to help you to learn to accept, to adapt, and to accommodate this damn awful illness. It doesn't diminish the fact that ME/CFS, is a real thing. If you need help to cope, then please get it. It doesn't diminish you, or it should not diminish you. So as I say, there's no effective treatments, unfortunately. There's no drug that we can say this will cure you of ME/CFS. So it's very much about learning how best to manage it. So again, specialist help, learning to manage physically and mentally, how to balance rest and sleep as and when you can. There are medicines that can help in general for some symptom relief, so pain relief, sleep, help with sleep perhaps. Dietary management, that can be quite important. Again, I think generally speaking, when people are at their worst with this illness, they tend to be underweight, or weight is not an issue in terms of being overweight at that phase. But as you become, I don't know, more stable perhaps, if your appetite improves and you start eating more, then obviously the nature of ME is that you're not physically fit, you're not physically active. So there can be a problem with weight gain. I mean, here I am, I'm overweight. And the reason is likely that I just am not able to exercise as much as I should to try and manage the weight. So dietary management can be important in terms of being underweight and in terms of being overweight. And again, you should have access to specialist dietitians through the specialist service. We do have a booklet, by the way, about treating ME/CFS. And then energy management, which is the real focus of management with ME and long COVID, of course. So it should examine all forms of activity, so cognitive, physical, emotional, and social, and whatever level you're at. Obviously, if you're very severely ill with ME, Hannah was in the severe category, I believe, when the video was made. If you're very severely ill, you're extremely, extremely, extremely unwell, and very, very limited in what you can do. So your management will be extremely limited as well. If you're not in the very severe category and you're in the severe category, in the moderate category, the mild category, you can obviously, or hopefully, be able to do more, but it still needs to be managed. You still need to try and prevent episodes of post-exertional malaise. And to do that, we adopt something we call pacing, which essentially tries to balance the energy that you have with the activities that you can do in a structured way. And again, we have a nice booklet that you can download there. Another infographic available for overall management, again, to share with a GP or to use yourselves. Just let me know if you'd like it, or it's available on the website, which can help, just as a reminder, particularly if you're a carer of somebody with ME, I think it's quite useful in that regard. We designed it actually for healthcare professionals who weren't specialists, so but it's a useful reminder. Another aspect of specialist services should be that they help you if you are in a position to return to work. Okay, so they should be able to offer to liaise with your employer, and the reverse is true as well. So if you're new to ME/CFS, you're getting a new diagnosis, or you've had a relapse, they should also be able to liaise with your employer to help you downsize at work, or to leave work if you need to leave because you can no longer work. Now, the extent to which they can help you out with employment depends largely on the resource at the moment of the specialist service itself. But it is another aspect that the NICE guideline says that, they should be doing. So we're trying to work with them on this to generally get more resource available for these specialist services. if you are having employment issues, by the way, we do have a really good booklet on it, and I wrote it, so it's got to be good. That's it, really. That's the end of my talk. Thank you very much. Sorry I went on and on and on, but I get a bit carried away. I won't dwell on that screen. I want to go to this screen. We are on every social media channel. Well, I say every. I mean, I don't keep up with social media very much anymore. I haven't got the time. But we've just gone on to Blue Sky. I need to update this, I think. But any questions at all, get in touch with me. That's my email address. You know, and if I can't help you, then I'll find somebody at the charity who can. So thank you very much.
Thank you, Russell. That's great. Really, really informative. And I think we could literally sit here and, go through this for hours. This is just so much, isn't it, to go through. Thank you so much for breaking down some of the medical jargon, because I think you've almost got to become a bit of an expert in it, haven't you? Sort of from that point of view. There's a few questions coming in. I would say for people who would prefer to just kind of contact Russell directly with a question or go through myself, you've got both of our email addresses. And Russell, if you wouldn't mind just sending us those 2 links that you mentioned, and we can send them out with the slides afterwards, the 2 infographics, that would be really useful. So we have a comment really just about someone who does experience fatigue, but they also have a diagnosis of fibromyalgia and functional neurological disorder. I think that was in relation to, sort of some points that you were making through the presentation. And someone who's saying that they've yet to meet a healthcare professional who understands ME and fibromyalgia. Several occasions been informed, don't know how to support, and don't have knowledge of ME. Bloods are fine. Despite white blood cells being raised, going up and down. Felt managing better despite not having quality of life. However, a COVID booster felt worse than the following day afterwards, and in quite a lot of pain now. And basically, this person is saying there needs to be more awareness within healthcare professionals, asking if you know of others who might have had issues with the COVID booster. And I think you've also mentioned that you are obviously doing this work as well, haven't you, with engaging the NHS, as part of this clinical conference that you're doing.
Yeah. So just to say about the vaccines, so throughout the whole process of, when we were all getting vaccinated for COVID, against COVID, and with the boosters, we were running surveys throughout the whole period, and there was a very mixed response. I think it's fair to say some people at some times with certain vaccines were having reactions, other people weren't. It seemed to be quite a mixed bag. So I don't think there's a general sort of there wasn't a trend. That's the wrong word probably, but I don't think I could point to a vaccine or a booster and say, don't take that one, try another one. It seemed to affect different people differently at different times, unfortunately. So, yeah.
Yeah. And I guess we're all individuals, aren't we? So I guess it can, as you say, kind of affect people differently. But certainly it sounds great, the additional work that you do and engage in, sort of with the NHS around awareness raising, and all of the research that's going on at the moment sounds absolutely fantastic. Just to point out, and you will, if you kind of follow us or, sign up for our newsletter, we are going to do a separate session in November with someone from the ME Association talking about the particular biomedical research. So if research is something that you're interested in, sort of definitely keep an eye out for that. That one will be on the 14th of November, and we'll advertise it nearer the time. So we also have a comment really about just, which I'm sure it's not, you're very aware of this, Russell. Unfortunately, a long way to go in terms of care for ME patients. Diagnosed in 2007, never seen any specialist, still resistance from some healthcare professionals to implement NICE guidelines, and, sort of psychological professionals who still point to the fact that it's, sort of just psychological.
Absolutely. And apologies from me if I sort of tended to focus on the positives in the presentation. There is an awful lot of work still to do. On the psychological side of things, I would say that I'm running a project at the moment with the British Psychological Society. We're producing good practice guidelines on ME/CFS. So these will reinforce the NICE guideline recommendations, and they will be going out to all the British Psychological Society members. So I'm hoping that'll feed down through to all of the psychologists that are involved in talking therapies, who you might be referred to outside of an ME service, but also to the psychologists working within an ME service. So that's one sort of development I can highlight. But I do agree there is an awful long way still to go. I think sometimes we kind of have to remember that the NHS has got to try and provide resource for everything. Right, it's huge, isn't it? And the task is huge. That's not to belittle that we're not important, because we are. And I will fight till my dying breath for people with ME and long COVID. We deserve as good a quality of healthcare as anybody else does. But it can be very hard to have our voices heard when I attend some of these board meetings with integrated care boards. We're making progress, but it's too slow, I think. I think the delivery plan is going to help. So for the last 3 years, we've been working with the Department of Health on the delivery plan for ME/CFS, and that's going to reinforce the NICE guideline and reinforce the need for good quality healthcare. That's now unlikely to be published until the middle of next month, but keep an eye out for that, because it'll generate a lot of interest, a lot of press attention, hopefully, although it's going to come on the heels of the 10-year health plan for the NHS. So yeah, the timing hasn't been ideal, but I think it'll help us. The last 3 years have been very important because we've been engaged at quite high levels within the NHS. And you've got to remember, right, that I don't know another disease that has had a delivery plan. So that's number one. Number two is this delivery plan was kicked off by a Conservative minister under the last government, and it survived a changing government, a new government, and two Department of Health ministers since Labour came into power. And all that time it stayed, and the importance has been there. And I think that says something. So, I think the delivery plan is going to have a positive impact. Not the impact everybody wants, unfortunately, but that's the way of things with government and policy. But it will have an impact.
So watch this space.
Hmm.
Yeah. Has anyone got any other questions? We've got a couple of minutes left. If anybody has, please pop them in the chat, or like I say, do contact us individually. We will send on the slides along with the recording as well, and do pass that on to anyone that you think is interested. Just a note from us that if you have any sort of personal experience, you live in Northumberland and you have any kind of experiences or feedback that you want to share about, experiences of care when it comes to ME, please do get in contact with us as well. And yeah, just keep, sort of in touch. As I say, we're doing a session in November as well. So we'll just wait a couple more minutes just to see if anything else comes in. But if not, I'd like to thank you, Russell, for coming along and talking to us today. As ever, you're just really knowledgeable, sort of on the situation, having obviously lived with the disease and worked, sort of with the ME Association for so long. And yeah, brilliant presentation. And thank you to everyone who's come along today and actually, took time to listen. And apologies if you were signed up for the last session. We did have some technical gremlins, which meant that we couldn't go ahead. So anyone else that who hasn't managed to come along today, please do feel free to, forward on the recording to them. So I think that's all for now. There'll just be a couple of thanks coming in. And again, yes, thank you very much, Russell. It's been amazing.
You're very welcome. I think Katrina's going to join you in November, is she? Deliver that research.
Yes,
Yes, lovely.
and we'll be doing
Wonderful.
a little bit more around sort of the biomedical research. So
Lovely.
yeah, really looking forward to hearing more about that, because it sounds like there's so much, going on, and as you've said, with the numbers set to grow, it's ever more important, isn't it? So
Brilliant.
yeah.
Okay.
Thanks,
Well,
everybody.
thank you all very much. Thank
Thank
you.
you. Take care.
All right. Bye.
Bye.